this week on the BackTable Podcast.
Is another technique that I often have to use with sclerotic bones where I basically take the cannula itself to the anterior third and then I almost like unsheath the ablation probe.
Okay.
So, because, the ablation probe, the OsteoCool, it's a little flimsy. Like, it's good for what it needs to do, but it's not meant to, drill through bone. So, a lot of times in sclerotic bone, if you're trying to push it forward, it may not go through. So, I've done different things where either you drill again and then try to create a little pathway, or a lot of times what I've had to do is just take the cannula fully anterior, take the interstylet out, put the ablation probe in, and then basically hold the ablation probe forward and then slowly back out your cannula to basically kind of almost like unsheathing it.
Yeah.
This way your OsteoCool kind of stays in the anterior 1/3 and you can back your cannula out. And this way you're not like fighting this super hard sclerotic bone.
This is Mike Barraza, returning as your host. I'm pleased to welcome back my friend Asad Baig, Interventional Radiologist and the Director of the Interventional Spine Center at Columbia University. How's it going, man?
Hey, Mike. Yeah, thanks for having me on. I don't know who messed up and decided to give me another podcast, but I appreciate you guys having me on.
Oh, dude, we're glad to have you back. What's new in New York?
Not much, New York is New York. Columbia's been good. Some exciting times. We've brought on some new people and got some great support from our leadership. It's a pretty good time to be at Columbia IR, so I'm pretty happy there. We've kind of expanded a lot of what we're doing in the IR realm, also in the spine realm. One of my colleagues is now doing some spine stuff too. So we're kind of expanding quite a bit. So it's exciting, man. It's fun times.
Good. I'm glad you have somebody to help you out with those cases. Today, we're going to focus on talking about spine ablation and kyphoplasty and primarily focus on some of the tougher cases. And so what I wanted to do at first, we have gone through everything, with OsteoCool before and kind of the workup and multidisciplinary management. It's kind of focusing more on the technical elements. What I wanted to do first is ask you, when you are evaluating a patient for a spine ablation, what is like the ideal patient in terms of, the lesion type and location, et cetera?
I think, number one, obviously, we're treating the patient, right? We're not treating the image. So, first and foremost, what are the patient's symptoms, right? Are they having pain at the site? Is it potentially like, post-radiation? Is it some sort of cancer? Is it Mets to the spine? So, all these factors come into play, but ultimately, probably the biggest thing, because, there's like a lot of treatment options out there, whether it comes to radiation or, depending on the situation, maybe even like, laminectomy infusion. But, when I am kind of thinking about, all right, am I going to ablate this or not? Most of the time it's, kypho plus ablation. But yeah, that's generally kind of who we're targeting, kind of the cancer population, the oncologic patients, and patients who are just having, quite frankly, kind of vertebrogenic pain. The pain that we talk about that is, worse with kind of getting in and out of bed, getting in and out of a car, things with bending forward flexion. These are all kind of things that we see with patients who have this kind of vertebrogenic pain. So if there's that plus tumor, then to me, it's kind of like, all right, this is a good case to ablate.
Are you doing exclusively metastases, or are you doing any, primary tumors or other types of lesions of the spine?
Yeah, I mean, pretty much any tumor in the spine you can ablate. And, the nice thing is, and I think we had kind of spoken about BVNA in like another episode, the nice thing about RFA and OsteoCool is, obviously the intent is tumor, but, you have to wonder, and obviously it's something that is, kind of advertised, but there are nerves there as well. So one has to wonder, like, yeah, we're going after tumor, we're killing tumor, but is there some kind of effect to the potential basivertebral nerve in that area as well? So yeah, these are kind of, things that I consider when I'm thinking about like ablation or not.
How do you approach these patients who are going to get radiation at some point or who have gotten radiation?
Yeah. Oh man, dude, that's a great question. And this is like the ever like going like, conversation with rad onc.
All the time.
Yeah, and you know what? I have to say that we've done a really good job of kind of working with our rad oncs at Columbia. There's a lot of data kind of talking about, radiation plus kypho, kind of the benefits of that, how it helps with overall kind of pain, quality of life, et cetera, et cetera. What I've kind of really kind of tried to do with the rad onc colleagues that we have is kind of let them know, like, hey, we can kind of support each other. We're not taking away from your radiation. If the patient's having a lot of back pain and you can't get to it right away, like, send them over to us. We'll do the kypho, we'll ablate, and then we'll send them over to you, and you guys can do your stim and all that. Your sim, sorry, I said stim. On the flip side, like, I've also done the alternative where, post radiation, there's depending on what you read, I think it's up to almost like 40% patients are going to get fractures after radiation. So a lot of rad oncs are worried about that anyway, so they'll send them over to me. But what I always tell them is, like, hey, let's coordinate. So, like, as soon as you're done with radiation, let me do the kypho within like the next week, and at the same time I'll ablate as well. So that's that, because the longer you wait, the more sclerotic the bone can become, and then it's kind of you're fighting an uphill battle there.
Right. The conversation I have to have a lot, and sometimes more than once with the same doctors, is just to remind them that this is not, this doesn't mean you can't get radiation. If I ablate you and do a kyphoplasty after, it's not that you can't radiate it. It actually may help better with the pain relief.
Exactly. And, I think in general in medicine, like, I think in some aspects there's, depending on who you are, depending on, what field you're in, there's always kind of that thought process that, oh, like, is this person or is this field kind of taken away from me or whatever. But, I think where we've moved kind of in medicine and definitely in the IR space, like, we're kind of a lot more collaborative now. And there are a lot of studies that show that kind of this kind of medicine is more beneficial to the patient. So, it's not like we're taken away from each other. I think there's a role for both kind of in the spine oncologic world.
Yeah, I mean, clearly there are great opportunities to do the ablation and kyphoplasty in somebody who's not getting radiation. But I do think that there is a sweet spot for, patients who are going to need both in terms of augmenting pain relief. And so when you do have those patients, they're going to get both. What do you prefer in terms of timing? Do you like to go before or after the radiation?
I mean, ideally, it would be perfect to go before, I think, because, they can still do their kind of sim after, I think in terms of bone quality, right? Like, after radiation, it's like one of two things is going to happen. It's either going to become sclerotic, and then, what I found in my patients is the patients that tend to not get, they get some relief, but not the pronounced effect of, kypho and ablation is like, it's usually the people who have gotten radiated and it's been, weeks or months later and they're sclerotic bone and, they're still in pain, so it's like there's that aspect, and then the other aspect also is, after radiation, like I think we mentioned this before, a lot of patients will get fractures, and kind of my thought process is radiation is really, really good at what it does, which is kind of killing everything in the bone. And when you get rid of everything, it's like you have nothing there to support. So it's kind of natural that you're going to have a fracture. So kind of for those reasons, I always try to propose like, hey, like we can do the kypho and ablation and then send them over to you. Depending on kind of the referral pattern and the patient's situation, it doesn't always happen that way. To answer your question, in an ideal world, I think that would be first kypho and ablation, then send over to rad onc. And sometimes it does happen. So,
So let's talk about, a hypothetical scenario, patient, who's in pain, has spine metastases. Ideally, what are you looking for in terms of, a candidate for an ablation and kyphoplasty?
The first thing that you want to kind of think about is, well, there's two things really, kind of, the patient's clinical picture, like what are their signs and symptoms. And then, also what does the imaging show? I think one of the lost arts is a physical exam and actually speaking to the patient. It's ironic because we are technically radiologists, so everything is about imaging. But in the IR world, I think we've moved, or we're moving at least to a place where like we really kind of put the patient first. And I think that is paramount when it comes to kind of spine treatments, whether it's ablation, kypho, anything like that. What I'm looking for is like exactly what you said, Mike. pain. Where is your pain? Is it kind of in the region of the lesion or the fracture? Or is it, like I have some patients who like have lesions in their lumbar spine and like their pain is thoracic. So it's like, well, sure, we can do it, but that's nowhere near where your pain is coming from. So, that's you're not going to get the result that you're expecting. The other things that, that I ask for patients is your pain primarily kind of in your back, or is it kind of shooting down the leg? Are you having radicular symptoms? I think one of the hardest things is kind of conveying to patients that like, I can't fix everything, like your back, like we can help with, right? But, if you've got radicular pain, like we may be speaking about a different issue. And I may, whether that's, due to a degenerative process or in the oncologic world, now we may have to say like, look, your tumor, and this is where the imaging comes in, your tumor, your lesion may be extending beyond the vertebrae. So if you're having these symptoms, if you're having any kind of, cord edema or anything like that, like we may have to refer you to either our rad-onc colleagues or potentially like neurosurgery or ortho spine. But, that's where kind of the collaborative process comes in. And what I always tell patients is like, I'm going to take what you're telling me your symptoms are, what my physical exam is showing, and then I'm going to correlate it with the imaging, and then we're going to come up with the best plan possible for you.
Okay. In terms of imaging, though, what are you really looking for to determine if a patient is a candidate for an ablation?
Yeah. So pretty much kind of any lesion that is going to kind of correlate to patient's pain or symptoms. Obviously, you want to stay within the vertebrae. One of the things I think to watch out for is your posterior aspect of the vertebral body. Is that intact? Or is tumor kind of invading? Is it going kind of posteriorly? Because now what would normally be a pretty safe procedure is now going to be potentially risky. So those are kind of the main things. Obviously, I think we talked about it before too as well, cord, any kind of cord edema or things like that. The other thing to also look for is, and I don't think this is necessarily a contraindication, but, if you don't have anything coming back posteriorly, but you have a little bit going into kind of one of the pedicles or even both of the pedicles, I think there is a role still for ablation and kypho, but you do have to be cognizant of the fact that, your pedicle probably doesn't have the integrity that you're used to or that you want.
So the one that's a hard no is tumor going through the posterior margin of the vertebral body.
Exactly. Yeah. Because, most of the time, if that's happening, they're most likely having symptoms beyond just vertebrogenic back pain. But if you see that on MRI and cord signal, definitely is. I just had a patient this past week with that exact thing with fractures. I think like T9 to T11 and then a couple lumbar fractures. But T10 was like so far kind of back posterior that there was like cord signal, and I was like, dude, I am not touching T10. I called the neurosurgeon that I work closely with, and I was like, look, I can do the other levels. I'm happy to help where I can, but this is something where I'm going to defer to you because cord signal and posterior, it's It's
interesting. Most of the ones that I have declined have been the ones that have shown up to clinic, and I look at it and it's like, you actually need a spine surgeon.
Yeah, exactly. And it's funny. It's like, it's interesting because in IR, we're always like, yes, we can do it. Yes, we can do it. That's one of the hardest things is like looking at a patient and being like, the right thing is for me not to do something, and I'm going to refer you to a colleague.
I think that's a challenge with a lot of these, though. With a lot of these that are kind of on the fence, it's like, man, like I think I can probably help this patient, but it's a little bit dodgy. And I'd like to spend some time kind of focusing on some of those where you look at it and it's not just like a clear lytic lesion in the center of the vertebral body with beautiful pedicles. You look at it, it's like, damn, like it's a little bit different, but can I still treat this? How do you approach the lesions that are mostly within the vertebral body, but maybe extend a little beyond it laterally or anteriorly, but not, into the spinal canal or neural foramen?
Yeah. So, I think you have to have kind of an honest conversation with the patient. And, you got to be like, look, here's the deal. I know you're in pain. I want to help you out and I'm going to try my best. Here's the imaging. I just want you to know that there is tumor that is kind of extending either superiorly or laterally or whatever. And, I think that if you do it in a safe way and you're very cognizant of kind of where your cement is going, where kind of all your instrumentation is going, I think you can still do it safely. I think a lot of it also has to do with just how bad kind of the patient's symptoms are, right? If the patient's really kind of not doing too bad or it's not something emergent, that might be something where I might say, hey, you can get radiated and come to me right after. But if it's only invading kind of a little bit of like cortex and it's something that, could probably safely be done, I have done those cases where it's like we would love, the ideal scenario where cortex is fully intact. It's just a nice lytic lesion just right dead center. But the tumors don't listen to us. Tumors don't read the textbooks. So I think when you do that, you just have to go back to your fundamentals, right? Like make sure that you're kind of avoiding medial aspect of the pedicle, right? Make sure that you're kind of getting as anterior as possible. You're medializing within the vertebral body, right? Making sure that kind of you're doing all the right things so that you kind of give yourself the best chance of success. And in those cases that I've done, I've been a little bit more on the cautious side in terms of like kind of, that saying the enemy of good is better, so maybe instead of pushing a little extra cement, maybe I'll just kind of stop a little bit early, just to make sure that we don't really have kind of that cement extravasation.
Do you take your ablation probe past the edge of the vertebral body for the ones that are extending maybe a little anterior laterally, or do you keep it within the vertebral body?
No, I would keep it within the vertebral body. Yeah, I would be really hesitant because, the thing when you start doing that is you kind of start losing control. One of the nice things about like OsteoCool and RFA is kind of the control of it, where it's, you know exactly where the burn is, right? You know the size of the burn, and you know that it's kind of going to be contained within the cortex. The moment that you have kind of invasion of the cortex, now you're talking about a different ball game, right? Like, sure, you still know the dimensions of it, but now it's kind of a little bit cowboyish where it's like, could it extend beyond the cortex? Yes. And then, you have to evaluate like, okay, what are the vital structures that are there? Like, could it potentially impact that? So that's where, you really kind of have to be judicious about, like, all right, should I do this or should I not?
How do you approach the lesions that are more eccentric within the vertebral body to one side or the other? So, it's really easy to go down one pedicle and get a probe into the lesion, but coming from the other pedicle, it's just really hard to get all the way across and get that into there. How do you approach those?
Yeah. So, I mean, I know a lot of people out there will use like a unipedicular approach, but I'm a big proponent of the bipedicular approach.
So am I.
Yeah. And, to me, I think that once you line up your imaging, like the access, it takes a few minutes, you know what I mean? So I don't think it's a time thing. But I think this kind of speaks to your question, right? Where you may have tumor that, exactly what you said, it's more towards one side or the other. In those cases where if there's one side that looks a lot better, I'll still go bipedicular, but I'll try to kind of cheat a little bit and see if I can get, the side that's a little bit easier to get into a little bit more kind of towards midline or even past midline if possible. And the nice thing about kind of the ablation is that this question reminds me of a case that I did, I think relatively recently, probably about 2 weeks ago or so, where I normally do bipedicular, but I actually, still used OsteoCool and whatever, but I just took a unipedicular approach. And I just started super lateral on the pedicle, and then I just made sure to totally come across. And then, instead of using 2 ablation probes, I just ended up using basically kind of the biggest ablation probe to kind of just cover the whole area.
Okay, good.
I think that's another technique potentially that you
that's
can
how
use.
I've done those as well, especially the ones that are kind of posterior in that vertebral body on that side. And, they maybe extended the pedicle a little bit, and I think that I'm glad to hear that you've done them the same.
Yeah.
Let's see, what else? So how high up are you willing to go for an ablation?
Oh man, that's a great question. I just did a T5 today, but I think the highest I've gone is T4. I higher than that, man, like your pedicles are like, at that point you might have to go extra pedicular at that point.
T5 is the highest for me. T5 is
it's even T5, man. It's like, depending on the situation, you could get lucky and have like great pedicles, but like even at T5, like everything's getting smaller up there and you just have to be really careful. Like we generally tend to use, like, I have a running joke with the reps, I use Medtronic a lot and OsteoCool, and it's like, it's always going to be blue, right? So I'm like, just like get it out. But the higher thoracic ones that I've done, it's usually been the smallest kind of ablation probe, just because you're so limited in space.
Limited space, the access is a challenge. But the other thing that I worry about, the higher up you go, and with some of these other lesions, it's not the ablation that I worry about a lot of the time. It's the cement, and if I'm using balloons. So in what scenarios do you not use balloons after an osteocool?
It's pretty rare, but sometimes if the bone is like super sclerotic, a lot of times what I'll do is I'll kind of do just a small inflation. So actually, this is a really nice topic that you brought up, because sometimes even after ballooning, what I'll do, if there's like a corner, if there's like, let's say for example, like left lateral, like, inferior corner, like there's not that much cement there. And this might be a little crazy, but sometimes what I'll do is I'll come back out to almost like mid pedicle, take the bevel, and then basically kind of just, drive it to that area.
I love that.
And then I don't balloon there, and then I'll just kind of just put a little cement and just kind of line it and slowly pull back and just kind of, to about mid vertebral body. But that's and I think the beauty of the bipedicular access is you have that flexibility where, like, let's say you end up, and you try to control the cement as best as possible, but sometimes it goes more superior, you don't get enough inferior. Like, you can do this where you kind of pull back and kind of just redirect it. And now, like, you wouldn't balloon after that, but at least now you've gotten your cannula back into a place where there's no cement, and now you've got the ability to put more cement.
I'm a big proponent of redirecting the cannula to add cement.
Yeah, it's one of those things where you don't think about it until one time you do it, and you're like, shoot, that was like why didn't I do this every single time?
So, I will very frequently bring mine back and cement, but you'll actually put the stylet back in the bevel and direct it down and somewhere else, and then just take it out and put your applicator back in and then just cement more.
Exactly.
I like that.
Yeah,
I gotta try that.
Obviously, before doing that, what I would do is, just make sure that you're not pulling back any cement on the cannula. Make sure that, you do your tap, tap, tap. Make sure that, you're that there's nothing hanging off of there, because you don't want to be pulling cement back there. But yeah, I think it's, the funny thing is too, I don't think anybody ever taught me that, but it was just something where I was just, to be honest, I was like really pissed off at one of my vertebral advisors, because I was like, man, and to be honest, this might be a little crazy, because the fracture cleft was superior, and we had, I'd coated the superior cleft like really well. But I was like, man, like I kind of just want to give a little bit of stability kind of at the inferior aspect too. And I was like, you know what, screw it. Let me just try this. And obviously very carefully, very, just watching it the whole time. And we are blessed. We have a biplane. So that makes it.
I won't do it without biplane anymore.
Yeah. It literally, it cuts time in like half. Like, it's like,
I am like way too particular about mine to do them with a uniplane system. Like that's how I had it in my last job. You make a little adjustment, then you go to lateral and then go back. And I don't work that way. And I have to watch, when I'm cementing the whole time. I'm really anal about that. I won't go back.
Yeah. Well, you have to.
You have to, and especially after an ablation, because I found that, after OsteoCool and after balloons, with tumor, you never know sometimes where that cement's going to go or how it's going to look.
That's a great point, because it doesn't always give you that nice, like, when you balloon, you usually get filling of the kind of space that you created. The tumor kind of, cementing that we end up doing, it's like, it almost like interdigitates sometimes. Like sometimes it'll go in the balloon. But, and that's the other thing, you had asked, like, when do you sometimes not do ballooning? Sometimes even, just the nature of the tumor, it's like one side, it's almost like your question with there's tumor on one side. If there's tumor on one side, it might be easier to balloon on one side than the other. You inevitably sometimes get these kind of asymmetric shaped looking balloons.
Yeah.
And you kind of just have to deal with that and just really watch the cement and make sure it doesn't go anywhere crazy.
Right. And it doesn't have to be pretty to work. I don't think that like a regular kyphoplasty, I can't really predict an outcome based on the cement distribution. I'll have one that looks ugly and the patient will just be like, I'm healed. Like, you know what I mean?
Exactly. Yeah. And that's another struggle because like we're all visual people, especially as radiologists, but also as humans, like we want to see like, oh, that picture on Twitter where it's like, it's fully filled in,
Right.
it's like, but you're so right, man. It's like we sometimes chase after that, but a lot of times, like if you just cement by like the fracture cleft, a lot of times like the patient feels like tremendous relief.
Are you doing many of these who already have significant height loss?
Yeah. So that's kind of the tragedy of this whole thing is that a lot of times, and we've increased our volume like exponentially.
Not bad.
Like we've gone from like 3 years ago, like barely doing any to I think 2 years ago we did like 43. I ended up doing like 40 of them. Last year we did 65. No, sorry, I did 65. I think as a division we did 70 or 80 something. And now this year we're probably going to crack like over probably somewhere between 100 to 150, something like that. So it's increasing tremendously. But Mike, what was your question? I was going somewhere with this and I forgot.
I don't remember. Oh, I was asking about, are you doing many of these who already have significant height loss?
Yes. Yeah. Even though our volume is like increasing tremendously, there's still so many patients who come to us like, I don't want to say like too late, but definitely later than they should, because like it's just a lot easier, and patients probably feel a lot better when we get to it kind of when you're not at vertebra plana or like way after the fact, and sometimes we see this too where like patients wait, well, sorry, I shouldn't say patients wait, but for whatever reason they come to us later than they should, and they start developing like kyphosis, and then people ask me about like, hey, like what can we do about kind of, I feel like I'm hunching over, and a lot of times it becomes really challenging when you get to that point where we can kind of do what we can, try to give you some height back, but a lot of that kind of structural stability or whatever you want to call it, in terms of the normal spine, you're losing when you get kyphotic. So yeah, so that's why, and there are countless studies that show that kind of the morbidity and mortality of like medical management versus kypho, and by extension kypho and ablation, it's like there's statistically significant differences there.
Yeah. How do you approach one from a technical standpoint, the ones with significant height loss, in terms of both your ablation and your kyphoplasty?
Yeah. So, obviously those are a lot more challenging. I, first and foremost, always kind of set the expectations with your patient. I always tell them, look, had you come to me, and I always tell them, look, I'm not blaming you. This is not your fault or anything like that. But the fact of the matter is like you have a lot less bone now, and the thing is just squished, really medical term, squished. No. So I tell them like, you really don't have that much bone left. So I'm going to do what I can. There is a chance that you may not get as much pain relief as you're expecting. The expectation I always set is 50% improvement in pain and a 50% improvement in functionality, right? Now, the actual approach to it, first, I always try and make sure that the pedicles are intact at least. Because if you've got this kind of, super compressed, almost vertebra plana situation, you want to make sure you can at least get into it. A lot of times when you're approaching that, your angles are going to be different. Most of the time when I've had these situations, it's been a situation where I have to go in with the bevel and I have to kind of take almost like, because it's almost always kind of compressed almost inferiorly. It's almost never like, superiorly going. So almost always it's the approach where I have to actually start superior at the pedicles, kind of really use that bevel. Make sure, by the way, in the lateral that, your foramen, that you see your foramen, because that's obviously super important. But especially in a patient like this, where you really don't have much real estate, you got to make sure that you're safe. So, that's what I would do. I would approach it kind of from a superior to inferior approach. And a lot of times there have been patients where like the height of the vertebrae is basically the size of the cannula.
Right.
And it's like, shoot, there's like very little margin for error. In situations like that, I may or may not use the drill. I may actually just use the bevel because of the directionality to basically kind of guide the cannula into kind of where I need to go, whether that's superior, inferior, things like that.
And so, after you do your ablation, are you ballooning these ones that are already, there's so much height loss?
Very gently, because it's exactly what you said. There's barely any height, so
Right.
my worry is always, yeah, exactly. Am I just gonna break through superior or even inferior, end plate? So I go up really, really slow. If it looks relatively uniform and it's kind of spreading out along the end plate, then in my head I'm like, okay, I have a little bit of wiggle room. If I have a little bit of wiggle room, I'll kind of slowly take up the balloon a little bit to see if I can get a little bit of height back. But the moment that it looks like it's kind of trying to sneak through, I'm like, crap, let's just stop. Let's just stop right here.
You're going to get some in the disc space.
Yeah.
And I really think that's okay.
Yeah, no, and I agree, because the big kind of boogeyman or boogie word or whatever you want to call it is always cement extravasation, right? I think in certain cases it may actually be okay, because you may actually just be coating the fracture cleft. And if a little bit gets into the disc space, most of the time the patient is not going to feel it. It's not going to cause any clinical impact. So, if a little bit gets into the disc space, it's generally kind of not going to have an impact. So it's okay. Obviously, you don't want to cement the whole disc or anything like that. But a lot of times, the coating of kind of the fracture cleft just above the kind of superior or inferior end plate sometimes actually kind of stabilizes it further.
Yeah, I'm with you. Are there any other scenarios you can think of that are particularly challenging or that change how you approach these?
Yeah, there are some. So for example, I guess you could call them almost like rescue cases, where I've had a couple where, patients had internal fixation, with rods and screws, and the screws have basically kind of migrated. This one case in particular that I'm thinking of, that was definitely a challenging case, because one of the screws basically migrated through the superior end plate. And what ended up happening is this patient actually got a compression fracture with the screw above it. It didn't start like that, but for whatever reason, it kind of migrated. So it was that was a really challenging case, because if you think about it, the screws that, the neurosurgeons or the ortho spine surgeons are putting in are basically transpedicular screws.
Right.
And that's our approach.
Right.
So in that case, I tried going bipedicular, but could not go bipedicular because one of the screws was directly in the pedicle. Luckily, the one that had migrated just enough where I was able to sneak below it. I basically kind of did a unipedicular approach, and luckily was able to get across and kind of cemented just underneath that superior kind of end plate and right underneath the screw. And that patient actually felt a lot better there.
That's awesome.
So yeah, that's definitely kind of challenging case. The other challenging cases are, kind of in a similar vein, where you have kind of one pedicle where you kind of just have to go fully across. I think, we spoke about this before, but the approach, generally, I think you're kind of okay with a little bit of wiggle room where just as long as you're in the pedicle. I think in cases like that, you really have to start just at the lateral edge of the pedicle. One of the things that kind of helps, where I tell the fellows this as well, is sometimes if you go over to kind of the oblique or the Scotty dog, sometimes it could be easier to find that kind of lateral aspect and kind of just dock in there. And then you can either just go right down there, or you can kind of take it back to AP. And then once you see you kind of have daylight right by, the medial aspect of the pedicle, you just kind of medialize that like hell and really try to get that across. Let me see, what other challenging cases? Yeah, in general, I think L5 can be a little tricky sometimes too.
I agree.
Because it's funny, if you go probably from probably T8 down, it's all pretty much very similar from T8 to L4 most of the time. Every so often L4 is a little weird, but they're going to be your kind of oval shaped pedicles and whatever. But L5 is kind of weird, because you almost have to take, instead of a 10 and 2 approach, 10 o'clock, 2 o'clock, it's almost like a 9 o'clock and 3 o'clock approach. And sometimes the pedicles will be wrapping around. So for those, I definitely always check kind of in the oblique in the Scotty dog. And those I will always start a little bit more lateral because I know I'm going to have to like medialize the hell out of that. And a lot of times because the lateral recess also comes into play, right? So at L5, you have the lateral recess, which basically kind of comes a little bit into the vertebral body, and you kind of have to clear that a little bit too. So, all those factors, that's definitely kind of a bit more of a challenging vertebral body, I'd say.
One more question for you. Sclerotic lesions in terms of ablation and kyphoplasty, do you approach them any differently rather, compared to a lytic lesion?
The one thing that I will do for sclerotic lesions, I'll use they have the tri-tip. It's the white handled one from Medtronic where it's just basically sharper. In terms of the actual ablation approach, I kind of, my approach with ablation is land it in, the tip and kind of the anterior 1/3 of the vertebral body, and you kind of want the tip almost at midline. This way you kind of have an overlapping burn zone. I don't necessarily change it for sclerotic bones versus kind of lytic lesions unless the lesion, like you mentioned before, is heavily on one side or the other.
Okay.
All else being equal, if it's in the middle, if it's lytic, if it's in the middle, if it's sclerotic. Now, the one thing that I do have to change though is definitely like getting that ablation probe in. Is another technique that I often have to use with sclerotic bones where I basically take the cannula itself to the anterior third and then I almost like unsheath the ablation probe.
Okay.
So because the ablation probe, the OsteoCool, it's a little flimsy. Like it's good for what it needs to do, but it's not meant to drill through bone. So a lot of times in sclerotic bone, if you're trying to push it forward, it may not go through. So I've done different things where either you drill again and then try to create a little pathway, or a lot of times what I've had to do is just take the cannula fully anterior, take the interstylet out, put the ablation probe in, and then basically hold the ablation probe forward and then slowly back out your cannula to basically kind of almost like unsheathing it.
Yeah.
This way your OsteoCool kind of stays in the anterior 1/3 and you can back your cannula out. And this way you're not like fighting this super hard sclerotic bone.
I've had that problem before. That's a good solution.
Join us next week for part 2 when Mike and Asad go through some cases.
Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable MSK on Instagram, X, or LinkedIn. BackTable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.